Welcome to the Total Joint Pre-Op Education class. My name is Ryan McIndoe and I am the Joint Center Coordinator of St. Alphonsus Health System. Today we'll be going over a lot of information, so please have a piece of paper and pen ready to write things down. We'll be covering everything from what to expect with this surgery, how to prepare before your surgery, and other items like how to minimize any sort of risk that can take place or how we're going to manage pain and nausea. If you have any questions, you will have my contact within your email as well. But again, have notes ready for this class. We have been doing total joint replacement for many years now here at St. Alphonsus. We have great trained orthopedic staff, and also you'll see that we have a team approach with your care after your surgery as well. We do have physical therapy who will see you, and possibly occupational therapy. They are going to say when you are moving safe enough to be able to discharge home. Of course, nursing will take care of you before you go home. Your surgeon will give you clearance surgically and say when you're surgically safe for discharge. And if they have ordered the medical team to take care of you, there will be nurse practitioner hospitalists who will give you the medical clearance needed before you can leave. So this means that before you discharge, you'll be deemed that you're moving safe, surgically safe, and medically safe. We do use clinical practice guidelines to make sure that you're getting the best approach possible for your care. These are put together by large orthopedic organizations and they are based off of the latest research. These guidelines can cover anything from anesthesia or how we manage your pain after your surgery. So just know that this is based off of a lot of research and your surgeons are using this for the best approach possible for your care. We will customize our therapy approach based off what you have for your needs and what your surgeon will want us to do as well. So the therapists do need to know things like, do you have multiple stairs to navigate at home? Do you have a walk-in shower or a tub shower? So that they can make sure you understand what you need to do to be safe at home. Plan on discharging anywhere from the same day of your surgery or 1 or 2 night stay. It is very rare that patients stay overnight anymore. Roughly 85% of our patients attempt to go home the same day of their surgery. And out of those, a very high percentage do end up going home as well. So it is rare that we have patients unexpectedly stay the night or even those who stay the night, but that is circumstances such as age, if they are, for instance, in their 90s, if there's physical issues outside of that total joint that you're having done, that requires a longer stay, but majority of patients do go home the same day and do very well. Our goal is to make sure you have a safe, comfortable, and quick recovery. It is a requirement from your surgeon that you have someone figured out to help you at home after your surgery. We call this person a coach. This person should be an adult to help for the first 3 nights at least, to help with mobility, meals, and medication. When we say helping with mobility, this does not mean that this person will have to help, for instance, pick you up from sitting to standing. You as the patient will have the strength to be able to do that on your own, but you will need help staying safe. This means the coach will help with things like bringing the walker over to you, getting any tripping hazard out of the way, turning the light on in your room at night, or opening the door to the bathroom. They're there to keep you safe with mobility for at least those 3 nights. You will also be going home with new medications after your surgery. These new meds will be overwhelming for you as a patient to keep track of. So they're going to keep track of the last time you had this medication and the next time that you can or should have that medication again until you get these new habits formed. This person should also drive you to your first follow-up appointment. You will have a 2-week follow-up appointment after your surgery. Do not expect to be able to drive yourself to this appointment. In fact, it'll take closer to 3 to 4 weeks before you can drive again, and we'll go over that in detail in an upcoming slide. The coach will also remind you of ways to stay safe. You have old habits that you need to stop and new habits you need to start to stay safe after the surgery. And those habits we'll be going over in these next couple slides, but they're there to keep you safe and teach you the new things that you have to start doing. Tell your coach thank you. We understand it's a lot for many people to take time out of their lives to help you. Some people are taking time off work to do this, and just tell them thank you because we understand the help that they provide is how we get you home into a safe environment. Your therapy sessions will begin on the day of surgery. You will work with physical therapy and, if possible, occupational therapy as well. Our goal is that everyone will walk a minimum of 10 feet, and more is encouraged. Most of our patients can meet this goal with no issue. We do have some patients who come in who have issues, for instance, if they are wheelchair bound prior to the surgery. For them to get up and walk 5 feet out and then 5 feet back can be a lot. Most patients can do more than that, and your therapist will encourage you to do more as they deem safe. If for some reason you are not able to pass therapy and you have to stay a night, understand that therapy will see you each day you are in the hospital, so the upcoming day, therapy will see you before you're deemed safe for discharge. We're going to go over specifically what does each therapy do when they help you. And starting with physical therapy, their roles include functional training, general mobility training, and safety training. I try to simplify this and say that they are going to teach you how you get from point A to point B safely and anything in between that you have to do. So let's say you're laying down in bed. They're going to train you how to go from laying down to sitting up edge of bed, how to stand up appropriately with your walker, how to walk safely with your walker and any stairs that you may have to do along the way. And then when you get to where you're going, how do you sit down safely as well into your chair? Again, everything from point A to point B and anything in between. If your surgeon wants you to be doing exercises after your surgery, they will also educate you on range of motion exercises and strength exercises. There are very specific goals that your therapist is looking at to deem you safe for discharge, and we'll go over those here real quick. First though, you'll notice the word independent is used multiple times. When we say independent, again, you can do things under your own strength, but you may need help with little things. For instance, when you get out of bed, you may need help getting the covers off your feet, but you're the one that's pushing yourself up from laying down to sitting. Your therapist will also have you demonstrate that you can do these without them helping you. So they will guide you on how to go from laying down to sitting up, but you are doing it under your own strength, demonstrating to them that you can do this for going home. So what are they going to watch you do? They're going to watch you independently get in and out of bed. Once you are sitting edge of bed, they'll then tell you how to stand up with your walker, but you will demonstrate that independently for them. You'll then independently walk 150 feet with your walker. Now when we say this, your therapist will be there to walk with you. You will have a belt that we place around your waist that they'll hold on to keep you safe, but you are under your own strength and balance walking 150 feet, and this can vary for the distance. What we want to see you be able to do is a household distance, which essentially is saying you are able to walk from one end of your house to the opposite end and back safely. So if you have a smaller apartment, we won't require 150 feet, and maybe less than that. If you have a larger house that you have to navigate more feet, then they're going to see you walk a little bit more than 150 feet. But that is our rough estimate for most patients. You need to demonstrate that you are safe to go up and down any steps. If you have one step to go up into your house, we have a platform that you can practice walking up onto and then stepping off the other side. If you have multiple steps, we do have a set of stairs, both with steeper steps and more shallow steps, depending on what you have to deal with, and you can practice those as well. So just know no matter what kind of steps you have to practice, we have the right kind to work with you on. We also want you to demonstrate that you are independent with any home exercise program that your surgeon wants us to train you on, and then throughout this entire process, with each step along the way, demonstrating that you are safe as well. If your surgeon has ordered occupational therapy, I will go over those things right now of what they would expect you to be able to do before you can discharge home. Also, again, if occupational therapy has not been ordered, your physical therapist can go over these same items as well. But what occupational therapy typically goes over are activities of daily living. Physical therapy taught you how to get up in the morning out of your bed, walk to your dresser to pull out your clothes, and then sit down in the chair that you're going to get dressed in. However, they didn't train you yet how to get dressed. So that's the area that occupational therapy focuses on. Lower body dressing, for instance. They're going to train you how do you get your clothes on and off for your legs, so underwear, pants or shorts, socks, or shoes as well. They're also going to train you on how to shower and do that safely, whether that be a tub shower or a walk-in shower. And then there's toileting as well. How do you get on and off your toilet, but also have good hygiene through that? And how do you manage your clothes while getting on and off the toilet and do that safely? That's what occupational therapy will go over. Both types of therapies are going to train you on medical equipment as well after your surgery. Understand that we have required equipment and optional equipment. So there's certain equipment we will say that you are required to use, and there's some equipment that is optional, and sometimes you don't find out that you need it till after your surgery. But we're going to go over these items right now. First of all, front-wheeled walker. You'll notice I'm circling it on the screen right now. A front-wheeled walker is the type that you want to get, not a four-wheeled walker. You can see the picture of the front-wheeled walker here. A four-wheeled walker is the type that has the handbrakes on it and has a seat that folds down that you can sit on. Those can work great after your surgery after a certain period of time. However, initially you need something more stable, and that's what the front-wheeled walker provides for you. You can handle a lot more weight through this type of walker and be safe with it, and they do glide along very well as well. You can many times get your front-wheeled walker covered by insurance. If you go this route, you will need a prescription from your surgeon sent to a medical supply store such as Norco. There are also other requirements that some insurance companies require. They may have a limit to how early you can get this before your surgery. What I suggest you doing is calling your insurance company to ask them any requirements for having this covered, so to make sure that you're not paying out of pocket by accident. The rest of these things can either be bought at these medical supply stores as well, out of pocket, or you can get these through, say, like a loaner program. That is like at St. Vincent de Paul store off of State Street, or there is Knights of Columbus in Nampa as well. And you can look up their number online, and they have very specific hours that they sometimes work under, but you can call them and ask them if they have the items to come and grab for free. You can also purchase these through many secondhand stores, which I would recommend calling ahead of time. Don't start driving around trying to find out if stores have them. Call them first, and if they have them, ask them to pull it aside and come pick them up. Also, many of these items as well, besides the walker, can be purchased online stores, such as Amazon or Walmart. I do not recommend you getting a walker from those stores as they're not as sturdy, but these other items that we're going to go over can work just fine that way too. The other required equipment besides a front-wheeled walker is some sort of shower chair. You'll notice the one on the left is a regular shower chair. That type works well with a walk-in shower and sometimes can work with a tub shower. But you'll notice the one next to it called a tub transfer bench. That one works very well with a tub. I'm going to try to simulate here how it hangs over the edge of a tub. And what you can see there, sorry for the little stray lines there, but essentially it is wide and it covers over the edge of the tub. This means that you can sit down onto the edge of the chair, start scooting yourself back, and then swing one leg in at a time into the tub. And then, of course, reverse when you get out, where you take one leg out at a time and scoot yourself closer to the edge of the chair before you stand up. It's wider to help accommodate that. These other items I'm going to go over are not necessarily needed. They will be helpful for some patients and some patients not. So, for instance, raised toilet seats. Now that the higher toilets are becoming more popular, then we don't need these as much. So the raised toilets that they call chair height toilets or comfort height toilets, if you put a raised toilet seat on those, they can be too tall and actually not be any benefit to you and make things harder. So if you have a higher toilet, you do not need one many times. If you have a lower toilet, kind of your standard height toilet, then these raised toilet seats can be very helpful. And if you're having trouble getting off your toilet right now, then most likely you'll need one after surgery for a little while. Reachers, those can be very helpful for getting clothes on and off if you are not able to reach down to your toes after your surgery. And so if you want to get one of those ahead of time, your therapist can train you on how to use those after your surgery as well. A shoe horn, if you want to get one of those, again, because you're having trouble getting shoes on and off currently, and you think that may be helpful after your surgery, then your shoe horn, if you want to get one, get a long-handled one. And then sock aids. Now, if you want to be very independent with your care, a sock aid can help with that portion. Some people are just fine with their coach helping getting their socks on and off. But a sock aid, essentially, you can get those online. That's the best place to get those, and they have a soft sock aid and a hard sock aid. And I really don't care which one you use. They both are very effective. But just know that, like in the picture here, it looks like a tube that is cut in half long ways. You slide your sock over it, and the other end has straps on it. Essentially, you throw it down onto the floor, holding onto the straps. You fish your toes in through the opened end of the tube itself, and as it goes close to the heel, you point your toes up towards you, and then you lift the straps going up over the back of your calf, bringing the sock up along the way. If you want to use one of those after your surgery and want to get it ahead of time, you can really bring these items as well into the hospital with you. But also understand, we require you to bring your front wheeled walker in with you that day of surgery so that we can make sure it is set up appropriately for you. These other items, if you would like to get training on, you can bring them in as well. Before using your walker, please make sure it is adjusted properly. To adjust the walker to the correct height, first stand in the middle of your walker. Hang your arms straight down at your side with your hands resting on the outside of the walker, not the inside. Now adjust the height to where your wrists meet the hand grips of your walker. With these proper adjustments, you will have your hands on the hand grips and your elbows will be slightly bent at around 30 degrees. Now to start with walking, first stand with good posture. This means you are not looking down at your feet, but instead looking straight forward. Do not stand hunched over, but stand as tall as possible. Take small steps. It will probably be easiest to first step with your surgical leg, followed by your non-surgical leg. With time, you'll be able to walk with a more normal gait and step through with each step, letting the walker glide you along. When walking, please use the handles of the walker for balance and keep yourself centered within the walker. Prior to sitting into a chair, back up to the chair and make sure that your legs, the backs of your legs, are touching the chair. You will need to be centered behind the chair. When you feel ready, move your surgical leg slightly forward. Support your weight on the non-surgical leg and reach for the chair arms. It is important not to use the walker to support your weight at this time, as the walker can slide out away from you, causing you to fall. When you feel ready, lower yourself into the chair. It is opposite order to standing, so just when you get ready to rise out of the chair, put that surgical leg forward, use both hands to push against the chair arms, and then put both hands on your walker, keeping your walker close to you. Do not have your walker too far out in front of you when you go to stand up. Using a walker with stairs can be difficult, and your therapist will go over how to do this after your surgery. Keep in mind though, the way that we say to do this is up with the good, down with the bad. That means when you step up, I'm going to step up with the non-surgical leg, and when I step down a step, I will step down with the surgical leg. Prior to using a cane, and just like with a walker, we need to make sure that it is fit properly before using. And just like with a walker, you want to hang your hands directly down at your side, have the hand grip for the cane come up to your wrist, so that when you reach your hand up to grab the hand grip of the cane, your elbow is slightly bent at around a 30-degree angle. When you are standing still, the cane should be approximately 4 inches to the side of your non-operative leg. This means the cane will be held in the opposite hand of your leg you had surgery on. It may feel awkward at first, but we are mimicking what it is like to walk normally. As you normally walk, your left arm swings forward as you take a step forward with your right leg, and vice versa. The same applies to walking with a cane. If you were to hold the cane in the same hand as the surgical leg, it will not help you walk smooth again, and it is not as stable. When you're ready to walk, move the cane forward the same distance and at the same time as your surgical leg. They will mirror one another. The cane is going to mirror that leg as in the picture. Practice this at home prior to surgery, and it'll take some time to get used to, but before long, it will become more natural. When utilizing stairs, just as we mentioned in the slide before, you go up with the good, down with the bad. You can talk with your therapist after surgery about how to do this exactly, especially considering some of you may or may not have handrails for the stairs that you may need to be using. Maybe it's a single step and maybe it's multiple steps, but talk with your therapist after surgery to get more guidance on this. Next, we'll discuss how to get in and out of a car after your surgery. For most people, the easiest kind of car to get in and out of is going to be your mid-sized SUV. Really what we're looking for is where the seat height-wise comes up to about the middle of your thigh when you're standing next to the car. If you have something that's lower like a sedan, you may use pillows or blankets to make it easier to get the seat a little bit higher for you to get in and out of. Before getting into the car, first things first, have the seat rolled back all the way and then slightly recline the seat back as well. You are going to use similar rules as when you go and get into a chair. Back up with the door open until you feel the door jamb hit behind your legs, keeping in mind that you have to keep the walker with you the whole time up to this point. Then you're going to move your surgical foot slightly forward. Reach back with one hand and help lower yourself down onto the seat using any grab handle or the door frame that's available. Don't forget to tuck your head forward to avoid hitting your head on the door frame. After you're seated, you can then scoot back more onto the seat. Lift your legs up one at a time and into the car. If you're having trouble or having a harder time getting your legs into the car, you can grasp underneath with both hands under your thigh. You can then lean back and lift your leg into the car this way. This is where it becomes important to have your seat rolled back and then recline back some to give you the most room possible to do this. Get your seat set comfortably for the drive, and then when it's time to get out, just do everything like this in reverse order, and then make sure that walker is right in front of you before you stand up. Just like getting out of a chair, don't have it too far forward, have it right next to you, right in the door jamb. So when you stand up, you can transition from pushing yourself up off the seat to then grabbing the walker itself when you stand up. It is also important to practice all of this prior to your surgery. So do the best you can right now. Practice it. Make sure you get comfortable with it, because this is one of more of the awkward things that you have to try to do after your surgery. When discussing safety as far as getting in and out of a tub shower or a walk-in shower, here's the main thing to remember. Falls can happen during bathing. Water makes the bathroom a very slippery place, so just make sure that you use a non-skid mat if appropriate to help prevent falls while in the shower. What can also be helpful is to have a handheld shower faucet in combination with using your shower chair, which reminder, regular shower chairs are more appropriate for a walk-in shower, and if you have a tub shower, if you can get one, a tub transfer bench is going to be more appropriate there. This will help you to be able to sit down and then reach all the areas necessary to bathe. Do not lean on things when you do get inside the shower itself. That means I'm not going to be supporting my weight with a towel bar or a shower curtain or a shower door, those sorts of things. Only use actual handbars that are attached to the wall and meant for this purpose. When getting in and out of a tub shower, this can be a little bit trickier. The main thing to remember is that you want to use this just like you're getting into a chair, where you step backwards until you feel the tub behind you. At this point, stick your surgical leg forward, slightly farther than the non-surgical leg. Reach back for the shower chair itself, and then slowly lower yourself using your hands again on the chair to help lower you down. Do not keep your hands the entire time on the walker. Once you're sitting, you can then scoot yourself back, whether you're using a transfer bench or a regular shower chair. Scoot yourself back, and then you'll lift your legs one at a time over the edge of the tub, and then get yourself comfortable and perform shower. When you are done, it's all in reverse order, lifting your legs back up and over the edge, scooting yourself closer to the edge, having the walker right in front of you, and then having one hand back at least, or two hands, and then one hand at a time reaching up and grabbing the walker as you stand up. But do not have that walker too far in front, and reminder not to slip on anything. Make sure that you're not stepping directly onto a wet surface that you can slip on. As far as getting in and out of a walk-in shower, this might be sound a little bit different than what you may think you should be doing with this, but many people have to walk in backwards into a walk-in shower, unless you have a very large one where it's easy to turn around and then sit down onto the shower chair itself. So for most people, what you will do is you'll turn around and then slowly, little tiny steps, walk backwards until you feel the lip of the shower hit the back of your feet. At this point, very carefully, one step at a time, step up and over the lip, and then bring the walker back with you. When you're inside the shower, you'll then walk backwards onto or right behind the shower chair itself, and just like getting into a chair, you will sit down on the shower chair itself. Get the walker out of the shower chair. We don't want that to get too wet. And then perform your shower. When you get out, you're going to walk forward and up and over the lip like you would normally do. Another thing to keep in mind, your post-operative bandage is waterproof. But what you want to do is please make sure it is not peeling off to help maintain a seal and avoid water leaking under the bandage. Once you're discharged from the hospital, your surgeon may want you to start doing some home exercises. What you need to remember is that our total hip patients usually do not start any physical therapy or even home exercises after surgery. If you feel that you may need to do some physical therapy, we will discuss this with you at your 2-week postoperative appointment. For a total knee patient, most patients will start doing exercises 24 hours after surgery and then start outpatient physical therapy after the 2-week appointment. As far as the best exercise you can do after surgery, that will be walking. We want you to do this and get up every 2 hours when you're awake during the day and be up for about 5 to 15 minutes. You can do simple tasks like going to the bathroom or going to the kitchen to get something to eat or going to take a shower, but every 2 hours during the day, get up for about 5 to 15 minutes to do a task. At night, please just sleep. You do not have to get up every 2 hours at night. If you have had a knee replacement, here are the exercises that you will perform. We call them the big 3 exercises. Again, you start them 24 hours after your surgery. You'll do these exercises once a day, and each exercise you'll perform a total of 15 times. The first one we call a straight leg raise. To do this exercise, sit up straight and on the edge of the chair, with your surgical leg extended out straight in front of you. Lift your leg straight up to the height of the chair seat and make sure that the top of your thigh, those are called the quadricep muscles, make sure those are contracting and that you're using those. Hold it there for a count of 3 and then slowly lower back down, again doing that 15 times. The second exercise is called a chair slide. To do this exercise, make sure that you keep your feet planted on the ground and that you're sitting back in your chair, sitting straight up. Make sure that surgical leg, that the foot is planted on the ground. You can have it slightly out in front of you, and just like you're going to get up and stand out of a chair. But what you're going to do is plant your hands each side of the chair, keeping your foot planted on that surgical leg, and then slowly scoot your butt forward on the chair, bending that knee. We're doing what we call passive motion. So what can help is to make sure that your thigh muscles are relaxed and not real tight as you do this. To help with that, keep in mind if you're tense elsewhere, you're going to be tense on your thighs. So make sure that your jaw isn't tight and that your shoulders aren't tight. Relax those and then relax your leg. And when you scoot forward, again, you'll get a bend in that knee. Our goal by the 2-week mark is that you will have a 90-degree bend in that knee. Just like you see here on the picture for this exercise, the foot that is out in front, that is roughly a 90-degree bend in that leg, which is the left leg in that picture. That's our goal. Hold it there, and then count to 3, and then slide back in the chair. If you feel you can get a slight more bend than 90 degrees, that's fine. Really, you can do 90 to 100 degrees those first 2 weeks and go from there, but don't overdo it. Again, perform this 15 times. The last one is called a chair hang. You do this exercise by sitting on the chair and then put a chair out in front of you and put your heel on that chair. This allows gravity to gently stretch the knee back to a straight position. Again, keeping in mind that you want your muscles in your thigh to relax, just as in with the second exercise. Keeping your toes pointed upright, do not let them drift to the side, and use your arms on the chair to help assist if necessary, but you'll hold that position for 15 minutes or what you can tolerate. I do not expect you, the day after surgery or so to be able to do this for 15 minutes, but do what you tolerate, and our goal is to get up to 15 minutes. Again, perform all these 3 exercises once a day. If you are doing really well and have no increased pain or swelling, then you can try to do these exercises later in the day for a second time, but do not push that right away. It'll take time before you can do that. It is possible after surgery that you may have certain restrictions or recommendations depending on your surgery. For hip replacements, we'll talk about that first. There may be precautions that will be applicable to you, keeping in mind that there's a few different approaches for hip replacement. First of all, if your surgeon tells you anterior approach is what you're going to be having for your surgery, there are no restrictions involved with this. However, what we will tell you is that you still need to make sure that you are not overdoing things and that you're keeping all your movements within reason. You also should listen to your pain and let that help guide you with what you can and cannot do. For instance, if you're reaching down to your toes to try to get socks on, and it starts to hurt as you're reaching down and getting close to your toes, don't push through pain to then try to get your socks on. Let that be your limit and figure out a different way to try to get your socks on, whether that's using an aid or having someone help you with it. So while we have no set restrictions, still let pain dictate what you can and cannot do in some of those circumstances. As far as a posterior approach hip, your doctor will tell you whether you have these 2 different types of approaches for precautions. When we talk about these precautions, these are in place for roughly 6 weeks to make sure that the soft tissue, so essentially the skin and muscles and everything, heal as they should around the joint. Most likely you will be given modified precautions after a posterior approach. That means that we do not want you really twisting the leg or the upper body, or try not to cause that foot to turn inward. In doing so, it can cause a risk for having a dislocation. We also say we do not want you crossing your legs at your knees. It is okay to cross your legs at your ankles, but no further, like up to the knees. As one of the surgeons also says, when in doubt, keep your knees out. And what we mean by this is don't be reaching outside of your legs or your knees down to your feet. Keep everything between your knees, so keep both hands between your knees as you try to get dressed and reach down to grab something off the floor if you're sitting down, getting your shoes on, getting your socks on. Hands between the knees, okay? And when in doubt, keep your knees out. It may be that you have strict restrictions. This is rare, but if this is the case, we will tell you that we do not want you turning that foot inward, like we already mentioned, so no twisting. We do not want you to bend past 90 degrees at your hip. This would mean that you cannot reach your hands past your knees. We say no crossing with your legs at your knees or your ankles. And then what we do not want you to do is a combination of turning your foot inward and then bending down as well. So just keep all that in mind. Again, that is rare to have those strict restrictions for those 6 weeks. Much more common that we see what we call modified restrictions with a posterior approach for 6 weeks. And if you have an anterior approach, we say no restrictions for those 6 weeks. And but again, letting pain dictate what you can and cannot do as far as movement as well, and keeping everything within reason. As far as knee replacements go, we want you to both bend and straighten that knee, which, this is like what we mentioned with those exercises. Bend and straighten the knee with a goal of having a 0 degree straight knee and a 90 degree bend or flexion in that knee. We do not want you to rest with your knee in the bent position. So what I mean by this is at night, I don't want you having your knee really bent as you sleep, or when you're sitting in a recliner, your legs are going to be up in the recliner, not with the reclining leg down and watching a whole movie that way for those 2 hours until you get up the next time. Keep your knees in a more straight position while you're resting. And this is going to be for both hip and knee patients. You are both going to be weight bearing as tolerated. What we mean by this is that you can put all your weight through your joint and it is not going to cause any harm. It will hurt doing so, but the hurting is not going to be causing any harm. So just keep that in mind. Just because it hurts does not mean you are causing harm to that joint. You are safe to put your weight through that immediately after surgery. As far as tolerating it, if you are not tolerating it, your therapist will teach you afterwards about how to use your walker to help walk in a way that you more tolerate when going through those steps. We also want you to avoid limping as much as possible and as soon as possible after surgery. The whole goal is that we have a good joint in there now and that we are going to try to get back to normal as soon as we can. Having a nice steady gait and smooth gait after your surgery will aid in your recovery. And we'll teach you on how to do that afterwards. Some good reminders is don't be walking with your legs straight if you are a total knee patient. Another way to think about that is walking like you have a peg leg. We want you to bend that knee and walk heel to toe, rocking that foot with each step that you take with a surgical leg. With a hip, sometimes people want to lock that hip up and they lift their foot up by lifting their pelvis up on that side. Again, use the hip. Walk heel to toe, bend the knee, bend the hip with each step, and then heel to toe, rock the foot forward as you walk through on that step. Use the hip and walk as smooth as you can as soon as you can. A lot of people have questions about sleeping. How do I sleep? Again, follow restrictions for that hip replacement if you have those. But what you can do is sleep on your back. You can sleep on your side, whatever is comfortable. You most likely will feel like you're Princess and the Pea for a little while, so have some pillows ready to stay comfortable during this time. And that you'll have pillows between your knees, for instance, or to lay into behind your back or in front of you. But have plenty of pillows to stay comfortable. And there are some of you too who will feel most comfortable sleeping in a recliner for a little while. If that's the case, that's fine. You can, spend a few nights sleeping in the recliner if that's what's most comfortable, making your way eventually to sleeping back in the bed. And as your pain and everything becomes more comfortable, then you'll be able to sleep more and know that this can take some time.
Hi there, my name is Emily Clay. I'm a registered and licensed dietitian here at St. Alphonsus. I was asked to be part of this presentation to discuss how nutrition can support you in the healing process in multiple different ways. So we're going to talk about nutrition and healing. We're going to talk about blood sugar control and decreasing our A1Cs if that is something we need to address. Maybe weight loss if that's something that may be beneficial for you in your new joint replacement. So to start off, we're just going to talk about nutrition and healing. So there is a lot of research that proves that if we have good protein stores going into any surgery, you heal better. So as you kind of prepare for your surgery, try to increase more protein into your diet. We know that surgical outcomes are better when we do this. We also know that after surgery, protein plays a huge role in healing. It helps heal our skin, our joints, helps maintain our muscle mass. It helps build muscle mass. So protein, you'll hear a lot from me today. Some good protein sources are listed there. Obviously, our meat sources like fish, chicken, turkey, beef, pork, tuna. Those are all great protein sources. Greek yogurt, 2% cottage cheese, protein supplements or drinks, eggs, string cheese, low sodium lunch meats are also good protein sources. And then if you are more vegetarian, beans, tofu, edamame, lentils, those are also pretty good protein sources that we can start consuming before your surgery and then continue afterwards. And that way we know we're getting a lot of protein, which will help your healing process. Some more information on protein. Because it is so important, we know that protein can help stabilize blood sugars. Protein by itself typically does not raise our blood sugars. So by incorporating more protein into our diet, our A1Cs can improve, our blood sugars are more stable, our energy is better, And we know when we're doing all of those things, if weight loss is a goal of yours, having more stable blood sugars will help in that goal. Protein also helps build and maintain our muscle mass. So eating adequate protein does not make you muscular. Exercise is what creates muscle mass, right? But if you want to repair that muscle mass and get stronger, you need to be eating adequate protein. Not only protein, you need to be eating adequate calories to do so. So by eating, 3 meals a day, every time you have a protein source, that makes that a little achievable. So a good practice is that you try to have a protein source at every meal and every snack that you consume. So an example of a snack would be like a small piece of fruit with a cheese stick. So you have a carbohydrate, which is the fruit, and then you have a cheese stick, which is a protein source. Maybe you will have some baby carrots dipped in peanut butter, for example. You have a vegetable with a protein source. Sliced cheese with 6 whole wheat crackers. So if you can kind of get in the habit of adding a protein source to every meal and snack, this will help your overall health and well-being, and certainly support your energy and mood and those kind of things. If you are interested in weight loss before surgery or after, we really need to be feeding our bodies adequately. So by eating 1 meal a day is not supporting your body, right? There's no way you can get all the nutrients that your body requires on eating 1 meal a day. So we should all be trying to eat at least 3 times a day. So breakfast, lunch, and dinner, whatever that looks like for you. And then at every meal, you have a protein source, like eggs, meat, or dairy. You have a fruit or vegetable, which is great fiber. It's great for our heart health, our brain health, our gut health, all of the things. Whole grains. Now, whole grains typically have a little more fiber and nutrients in them. So switching to brown rice or whole wheat pasta or whole wheat bread or whole grain bread, it's a great energy source. Carbohydrates do give us energy, and they shouldn't be avoided, but they should be part of the meal and not the entire meal. We should be consuming healthy fat sources like olive oil, avocados, avocado oil, nuts, seeds. We should try to limit butter and fried fats and trans fats. Fried foods, I mean. So by adding healthy fat and a whole grain and a fruit and vegetable, we feel more satisfied. Your body has gotten a complete meal, which can help with, boredom eating or snacking or cravings, all of those things. So if you eat 3 good meals with all of those things included, oftentimes you feel more in control of the snacking and some of the things that some of us deal with. It helps with blood sugar control when we have all the things at each meal. So really strive for that. And I have a picture of this on the next slide. But the other thing I wanted to mention about weight loss is monitoring how much sugar you're consuming. We know that A, spikes blood sugar, B, is not nutritious. It's not offering your body any nutrition really. And pay attention especially to our liquids. If we can cut back on high sugar beverages like soda, specialty coffees, Gatorade, sweet teas, lemonade, those kind of things. It's an easy way to get less calories consumed, which can help support weight loss goals. It helps with our blood sugar control, which helps support our weight loss goals and our A1Cs and healing and all of that. So pay attention to that. We should all be striving for about 64 ounces of water, unless you have some sort of cardiac issues where your cardiologist told you that you should be not drinking that much, but adequate for most people with about 64 ounces of water. So strive for that every day. We know that if we're adequately hydrated, sometimes that can prevent cravings and that kind of stuff. So water is good for that. We should be focusing on non-caffeinated, non-carbonated beverages for most of our beverage intake. So this is a good guideline if we're trying to eat a good protein source, fruits and vegetables, whole grains. This is kind of a visual picture on what that might look like. So on the top right-hand side of the plate, you can see whole grains. So using like whole wheat bread, whole grain pasta, brown rice, and the portion size is about a quarter of the plate. Right below that is your healthy protein. So fish, chicken, beans, pork, fish, I think I said that. These are great protein sources. So, a little more than a quarter should be your protein. So you have that on there. And then you can see that the vegetable piece of that plate is a little bit bigger, right? Because vegetables tend to be high in fiber, low in calories. They are typically not raising your blood sugar, right? And then obviously having a little fruit with every meal and snack. This is how we get our fiber up, which is great for our heart health and our brain health and our digestive health. So have your plates, fruits and vegetables. And if you can model this for most of your meals, you're eating a very balanced plate. And then obviously in the top left there, it says healthy oils. We should probably be eating, cooking with olive oil or avocado oil or even canola oil, limiting extra butter and those kind of things, because those are saturated fats. But it doesn't mean you can't have them all the time, but it's trying to just change the way we're looking at our plate and how we're doing that. Okay, so in conclusion, nutrition does help with the healing process, blood sugar control, any weight loss or weight gain goals you may have. If you feel like that you would benefit from having something a little more individualized, if you have food allergies or lots of food preferences, we can certainly work with you one-on-one. Our number is listed there. It's 208-367-7190. Even if you have a quick question, please don't hesitate to call. And I think that's it. So I wish you well and hope you have a great day, and look forward to hearing from you if you need to. So thank you.
We have completed the therapy portion and nutrition portion of the education. We're now going to go over preparation leading up to your surgery. We are going to start with your pre-admission testing appointment. If you have questions about the time and date of this appointment, there's two different ways to look this up. If it's one of our St. Alphonsus surgeons, you can look this up through MyChart or call their office. If it's an independent surgeon, then call their office and they'll be able to provide you the date and time for this appointment. Expect this appointment to be 1 to 2 weeks and possibly 3 weeks before your surgery. You will come in through the main entrance of the St. Alphonsus Hospital for this appointment. This is the large roundabout entrance that is by the central tower, the 9th floor tower. You'll come in through the main entrance there and check in at the front desk. Once you check in at the front desk, they will lead you over through a couple double doors right next to them, and that is where your appointment will take place. The purpose of this appointment is to obtain baseline information about you. We want to get lab work on you, along with a very extensive health and surgical screening history. They will also get medical history as far as medications you take at home, and then an EKG if there is nothing that's been done recently, and any other further tests depending on your medical history as well. The nurse practitioner hospitalist team will see you at this appointment as well. They do a very extensive job of going through everything to make sure again that you have medical clearance. They will give you a lot of education, and this will include medication education as well. You'll notice at the very bottom of the slide it talks about stopping certain medications before your surgery. They are going to tell you to stop taking aspirin and other types of anti-inflammatories leading up to your surgery. These will also include, for instance, ibuprofen or Advil, Aleve or naproxen. Those are other common ones that we see, and those can affect your bleeding. During this time, it is safe to take Tylenol. That will not affect your bleeding. They will also educate you on stopping any anticoagulants that you may be taking leading up to the surgery, and understand that they do a very good job of reaching out to the physician who has prescribed it to make sure that it is safe for when to stop this before your surgery. And this is to limit bleeding for both the anti-inflammatories and the anticoagulants. All over-the-counter herbs, supplements, multivitamins will be stopped at least 7 days before surgery as well. The idea here is that not only can some of those affect bleeding, such as fish oils and turmeric, but some of these can actually affect anesthesia as well. So they're going to have you stop all of them leading up to your surgery. They're also going to go over the medications you should take that morning of surgery. So yes, we are starting to limit that week ahead of time of what you can take, but there are also very important medications that you will need to take the morning of your surgery. These can include heart medications. These can include your thyroid medication if you take anything for diabetes. And so they are going to go over that about medications you stop, but also medications you need to keep taking, especially the morning of your surgery. These nurse practitioners are going to give you a bag with a scrub and a sponge in it with directions as well. And they will educate you on this. I will give you an overview, but when you go to this appointment, you will get more education as well that's more in depth. This scrub is called CHG. Chlorhexidine gluconate is the longer name to it. Also, more of a brand name is called Hibiclens. You will use this a total of 3 times before your surgery, but you will start 2 days before the surgery happens, and the last time, the 3rd time, will be the day of your surgery. So for instance, if you have surgery on a Monday, you will start on a Saturday and take again on a Sunday, and then use again on that Monday, the morning of your surgery. You will use this scrub after your soap, and you will use it everywhere below your shoulders except your groin. So again, do not use on your face, on your scalp, or your groin. You'll get the education on how to use this at the appointment. But here are a few highlights with this. Do not do anything that causes you to get dirty again. This scrub cleans bacteria off your skin, which helps minimize your risk for infection. Use a clean towel each time that you dry off, and do not hang that towel back up to dry. And when you use a washcloth to spread this around on your body, do not use that washcloth again. Both of those will go in the dirty clothes, and have a clean washcloth and towel to use the next time. The sponge that they give you will be used on that last morning before your surgery. So the morning of your surgery, use that sponge around that joint that you're having surgery on, whether it be that hip or knee. You will change your sheets on that first day. So when you start using the scrub, we recommend you use the scrub at night, and then put clean sheets on your bed to get into that are nice and clean as well. Do not use lotion after performing the scrub. The idea that we have here for using it 3 times is that you will not be perfect each time you use the scrub. You will not get everywhere that you're supposed to. And so when you do 3 unperfect times, many times it leads to full coverage all over your body. Do not use lotion, because if you missed a small spot on your body and there's bacteria sitting there, you're going to rub that lotion over that spot and then up and down your legs, and now we're back to square one where we've rubbed that bacteria all up and down your legs. Do not shave your legs for 7 days prior to surgery as well. What we're actually saying here is we want you to be careful and not have cuts where there can be a site for infection to come into your body. And so we also say be careful. There's a lot of patients who try to do a lot of jobs before they have the surgery. So, be careful if you're trimming rose bushes, things like that. What we're trying to say is do not get cut up really bad, because there are some surgeons who are more strict than others who will delay surgery if we have open cuts on their body, especially around the site of the surgery, and will want those to heal before they can do surgery again. You will want to spend time the weeks leading up to your surgery with getting your home prepared. Do not wait last minute, because this can be overwhelming for many patients. What you want to start doing before your surgery is make sure you have plenty of laundry ready, so that when you go home, your clothes are nice and clean and you don't have to play catch up. This also means that you want to have towels done for your showering, like we mentioned already, along with those washcloths and those sheets. If you have pets, this next section is for you. Once you start using that scrub the 2 days before your surgery, please do not have any of your pets sleep in the bed with you. Many surgeons are strict on this. In fact, they will tell you no pets in the bed with you for 2 weeks after your surgery as well. We are trying to prevent infection, and pets can be a source of infection after your surgery, so we take this very serious. If you have more questions on this, I would recommend you asking your surgeon at your last appointment before your surgery. Please pick up throw rugs, electrical cords, and any tripping hazard and get them out of the way. So runners, those types of rugs, if you have large area rugs that you can't get up, that's okay, but any rug that you can get up and get out of the way, please do that. Not only can you trip over those as you're walking, especially if a corner is starting to curl up, but they can get caught up in your walker as well and cause a tripping hazard that way. Electrical cords can be an issue as well. And so if they're going across a walkway, please figure out a different way to plug those in so that you're not tripping over those after your surgery. I do highly recommend getting, again ahead of time, the walker. Have the walker before your surgery if possible. And if you can do this, then walk through your house with the walker before your surgery. I want you to get familiar with your house, with how to navigate it with your walker. It is hard for many patients to, for instance, to get around in their bathroom. And so please figure that out before surgery of how to use your walker inside your bathroom. Also, you may find that furniture can get in the way and you didn't realize how you can't squeeze by it with your walker. For instance, a common one I hear is patients complaining that they could not get between their dresser and their bed to get either to the bathroom from their bed or to get into their side of the bed. So walk through your entire house with your walker before surgery and make sure you know how to get around it and that you don't have to move any furniture beforehand to make it safe. The nurse practitioner hospitalist at your pre-admission testing appointment will also go over bowel care. Now keep in mind, we are not talking like a bowel prep that you would have for a colonoscopy, so don't worry that way. However, we do want you starting taking something before your surgery to help decrease your risk for constipation. If you have a history of this with past surgeries, please talk with them at this appointment about your issues. What we ask all patients to do is start with a stool softener, which is like Colace. That's a common name that you'll hear. It's just over the counter that you can pick up at any store. Or a fiber supplement. That would be something like Miralax or Metamucil. And start one of those at least 3 days before your surgery. I will tell you, if you want to choose a fiber supplement, fiber takes lots of water to work. So if you're not a big water drinker, you will need to start drinking an adequate amount of water, like they mentioned in the nutrition part of this education. Probably at least 64 ounces a day. That is 8 8-ounce glasses a day. If you are not a big water drinker, then I would suggest you at least doing the stool softener. And then when you start one of these, please start on what they call more of your maintenance dose or preventative dose. You will notice there's different dosing on this. One to prevent constipation and other dosing if you actually have to treat current constipation. And so take the lesser amount and that will help you out. We have to be ahead of it because anesthesia can cause constipation. Your opiate pain medication can cause constipation and you're not walking as much. So starting this 3 days ahead of time will have something in effect by the time surgery takes place. Next, we will go over what to pack. And the first step is just to make sure that you keep it to simple items. Don't pack more than what you need. We'll go over those things here real quick. First off, if you had the booklet printed, you can bring that with you. And if you are unsure if you have a copy of our living will or direct power of attorney within our electronic system for your health record, then you can bring that with you on the day of surgery. Bring a copy and we can scan it into your electronic chart at that point. Comfortable, loose-fitting clothing, shorts, pants, or 1 or 2 changes. You want to make sure it's definitely loose around your hips if you're having a total hip replacement, so something like sweatpants or basketball shorts work out really well. Same thing if you have a total knee replacement, nothing real tight on the legs, around the knees especially, will be most comfortable. If you plan on staying the night, you can bring a couple changes. If you plan on leaving home that same day of your surgery, you can always wear the same clothes in that you plan on wearing home, and that will make packing even easier. Rubber-soled shoes with a back, easy to get on and off, closed heel, closed toe. What we're trying to say here is we don't want to see anything like flip-flops or Birkenstocks or Crocs. What we'd rather see are something like those Skechers slip-on shoes, or even if it's wintertime, those nice warm moccasin slippers. As long as they've got the closed heel, closed toe, rubber-soled, then we're going to be good. You can bring your own personal hygiene items if you would like, or you can have us supply them for you. We have the basics like toothpaste, toothbrush, comb, lotion, that sort of stuff. So if you want to make your life easier, we can always supply those for you. Bring your walker and then make sure that it's easily distinguishable so that we can keep track of it even easier. And what I do recommend is bring it in with you when you check in that morning. Don't leave it in the car so that you don't have to walk back out to have your coach go grab that and bring back in later in the day. If you happen to use a CPAP or BiPAP, what I recommend doing is bringing in the mask with the adapter attached to the mask. If you would like, you can also bring the hose, but we do not have you use your home CPAP machine in the hospital. We will supply our own CPAP machine and can use that as needed. Again, bring the mask with the adapter that attaches to the hose. Valuables, leave those at home. Any sort of jewelry like earrings, necklace, watches, rings, you have to take those off for surgery, and we just recommend leaving them at home, and that makes everything easier for you for what to keep track of before you go home on your end. You do have valuables you need, however, and those are glasses, hearing aids, dentures. If you have either of those items, any of those, then what we recommend is bring them. However, bring the case that they go into. And when you are done using them, put them directly back into the case. Do not leave them on a food tray as it gets mixed up with other things like with napkins, that sort of stuff, or with the lid to the actual plate itself. And it's too easy to have those things actually get taken off with the food tray. And so the recommendation is bring those, but put them directly into the case when you're done. And then if you want to bring cell phones, that's okay. We do have free Wi-Fi you can hook up to. You will be given an Ensure pre-surgery drink, which is a clear carbohydrate drink, at your pre-admission testing appointment, along with directions on when to drink this. Unlike what it used to be where we said there is no food or drink after midnight before your surgery, we are now wanting you to at least drink. We will still say no breakfast the morning of your surgery. However, the night before, to drink a certain amount of water, and then the morning of your surgery to drink a certain amount of water, and this Ensure drink. Again, do not get it confused with other types of Ensure drink. This is a pre-surgery drink specifically made for this. It does empty out of your stomach very fast, within half an hour from the time you drink it, which keeps you safe for surgery. This also, by staying hydrated, will improve your outcomes after your surgery. It will help with your kidneys as they have to filter out all the medications you're receiving that morning, which does in turn lead to better outcomes with less nausea and all that. We do want you to drink this Ensure drink before you leave your house the morning of your surgery, and then nothing else after that. Also, if you are a coffee drinker, please talk with your surgeon ahead of time or talk with the nurse practitioner at this appointment about what you are allowed to do. Again, no breakfast that morning. You will perform your scrub that morning before you come into the hospital. And as a reminder, no lotion, but also no makeup, no fingernail polish if possible that day of surgery. And then do not forget to bring those items that you packed into the car. That can be a common thing with patients if they're in a hurry, is that they forget those items at their house. The morning of your surgery, you will come to the main entrance of the central tower, just like you did for your pre-admission testing appointment. When you come in through those front doors, please check in at the front desk. You'll be directed from there to go to the surgery waiting area, and from there you will go to the pre-op area. We call it surgery prep and recovery. You are allowed to have visitors in this area at this time. When you get prepped, it's roughly a 2-hour process until your surgery takes place. During this time, they're going to review a lot of medical and surgical history once again. You'll notice that there are very similar questions that will be asked during this portion, just like you had during your pre-admission testing appointment. In the medical field, we do lots of double and triple checking to make sure everything is correct, but also we want to make sure nothing has changed from previous appointments. They are going to verify any medication that you had that morning, so please, again, follow what the nurse practitioner hospitalist has told you to take that morning of your surgery. They also will insert an IV and have that ready for the surgery, and then you'll meet with the anesthesiologist, and they're going to discuss the type of anesthesia you'll be receiving that morning. I'm not allowed to give you a whole lot of information as a nurse on this, but what I can tell you is that roughly 85 to 90% of our patients go through the surgery with having spinal anesthesia. This is a medication that is injected in your lower spine by the anesthesiologist that makes it so you are numb from your waist down. Because of this, you do not have to have full general anesthesia. You will still have an anesthesia to help you sleep during the surgery, but it's a lot closer to like a conscious sedation that you would receive when having a colonoscopy. You will talk with the anesthesiologist about this, knowing that our surgeons highly recommend you going through a spinal anesthesia, but there are some patients who are not good candidates for this. For instance, if you have severe arthritis in your lower back, or have had some sort of spinal surgery, such as a fusion, where they have placed hardware in your back. And if this is the case, your anesthesiologist will let you know that it is safer to, in this case, have general anesthesia. But please, any questions about anesthesia, you can talk with your surgeon at your last appointment before surgery, but you will also talk with them that morning of surgery directly with the anesthesiologist. And when you are comfortable with the plan, you will sign the consent for the anesthesia you'll be receiving. Also, what your surgeon or his or her assistants will come by and talk with you about the surgery itself again one last time, and they're going to then sign the leg and the joint that you are having surgery on. After prep, you will be wheeled over to the operating room. Know that you'll be in the operating room for about 2 hours. This includes surgical prep, where they will get you positioned onto the table and draped and cleaned. And what we used to do more often was insert a Foley catheter during this time. A Foley catheter is a line that they insert all the way up to your bladder that then empties any urine that you're making. Instead, what we do now for vast majority of our patients is we have you pee while you're in the prep area the morning of your surgery. That way you'll have an empty bladder during your surgery, and then after your surgery you will then be monitored based off our guidelines and orders to make sure that we keep your bladder within a certain range of how full we would want it to be. We will make sure that we get you up to go to the bathroom and pee once you are safe to do so. We do have an ultrasound machine that we can then use to also keep track of how full your bladder is. And if needed, we can intervene based off our orders to then insert a catheter to empty that bladder if you are unable to pee afterwards. It is a very low percentage that this happens with patients. However, if needed, we have it available. All this is to give you the best outcome possible and to minimize the catheterizations. By doing so, we will minimize the risk of having any sort of urinary tract infection and helping you have the best outcome possible. Once your surgery is completed, we also transfer you to the bed that you will recover in. So that is the nice part about this, is that you won't have to worry about transferring to another bed out of the OR. You'll be placed straight into the bed that you recover in. The next place you'll go after the OR will be into the first phase of recovery. We also call this PACU. There is no family allowed in this area until you go to your next phase of recovery, which we'll talk about the next slide. You'll be here roughly 1 to 2 hours on average. There's multiple things that need to happen before you can leave PACU. First, we'll closely monitor your vital signs. Make sure that your blood pressure is stable, temperature, heart rate, respiratory rate, oxygen levels, that those are both stable and remain stable. We'll assure that anesthesia is wearing off. So this means that if you had general anesthesia, that you're waking up well and coherent and everything. We also want to make sure that if you've had the spinal anesthesia, that your legs are starting to wake up. In this area, they'll also manage your pain after surgery, especially with you becoming conscious again and waking up, and that if you have any nausea during this time, that it is being managed. Before you can leave this area, you do need to get cleared by anesthesia. And so there's an anesthesiologist in this area who will come and look over everything and give the recommendation of when you can leave this area. Next, you're going to go to your phase 2 of recovery. This will either be back in the surgery prep and recovery area if you're in Boise. It could be on the nursing floor, but most likely you're going to go back to the same place that you got prepped in. At this point, family can come and see you again, and we'll start eating. We're going to start with ice chips, and we'll advance your diet as you tolerate. So just keep in mind, we're not going to have actual lunch right off the bat. Let's make sure you can handle ice chips or Jell-O or crackers, pudding, whatever sounds good that way, and then we'll move to lunch if you handle that fine. We will do frequent vital signs and assessments while you're here, and if you end up having to stay the night, then we'll continue doing those as long as you are here. We'll monitor swelling to that surgical extremity. There are some people who swell earlier than others, so we'll give you some pointers on how to minimize swelling during this time, such as using ice and elevation, and let you know how to deal with all that. If you've had a spinal block, that means you'll have numbness, and so we'll monitor and assess that while you're in this phase of recovery. We will not get you up and walk unless you are safe to do so, and that means that you have full strength back in your legs and full sensation before we can do that. We will start the pain management program, which I'll talk about that more in detail here in a few slides. And then you will walk with physical therapy or nursing staff day of surgery. That is the expectation, again, that you're going to get up and walk day of surgery at least 10 feet, but of course more is encouraged if you can do that. We are going to try to stop IV fluids as soon as you are able to drink water and not have nausea with that. Same thing goes with oxygen. We will not keep that on you unless you absolutely need it, and so we will remove that and trial you without any oxygen on and make sure that you keep your oxygen levels up and in the area that we want to see it at. However, keep this in mind. If you do need to stay the night for some reason, such as if you have low blood pressures, dizziness, nausea that we can't control, which keeps you overnight, then we may keep one or both of these on during that time. But as soon as you can tolerate and are doing well, we will remove those. The IV will stay in, but we'll just disconnect it, and again we'll have the oxygen at least there if we need to put it back on. We will continue with that pain management program if you've had to stay the night, and if you stayed the night, don't be surprised if they have to draw any labs that morning, and they do come early, so that the doctors who do round early have them all there and ready to read. No matter what, after your surgery, and when it's safe to do so, we are going to get you dressed. We'll get you up and acting like you're normal, sitting in a chair if we can, or a recliner depending on where you're at, and just mimic everything that we can do that you need to do at home, and make sure you can do that safely. As promised, we're going to talk about your pain management program, just about how we approach pain and the medications we give you for your pain. Keep in mind, pain is subjective. That means you tell us what your pain is and we medicate you based off of that, and that we do use the 0 to 10 scale for your pain. We want you to have good communication with nursing staff around your pain. This means I want you to tell your nursing staff if your pain medication that you were given is working or if it's not working and we need to bring something else in. So good communication either way, especially if you plan on leaving the same day. Because we're talking about you're staying for hours rather than days, if that's the case, and if we want to have a good efficient time before you leave and not be wasting any time, just have good communication with your nurse if they're not there in the room to ask you at that time. We need to have a realistic goal for your pain, so you are going to have pain after surgery. In fact, having some sort of level of pain will help give you boundaries on what you can and cannot do after surgery. So some pain is actually good, but we want it to be tolerable pain. Another way to think about this more simply is comfortable pain. So yes, I have pain, but I can still sleep. Or yes, I have pain, I can still perform the task that I need to do, like get up and go to the bathroom or go shower, and I don't have to stop what I'm doing because of the pain. Uncomfortable levels of pain or intolerable levels of pain, so that's where you can't do those things. I can't sleep, I can't do the task I need to do. That's not the expectation. Comfortable levels of pain is, and you can think of it as about a 2 to a 4 for a realistic goal for your pain on that 0 to 10 scale. We do use what we call multimodal pain management. This is essentially saying that we use medications that work in different ways and in specific ways. So not every medication we have you take at home works the same way. When they work in these separate specific ways, combined we have more of a complete control of your pain, and this helps us stay away from those opiate pain medications as much, especially compared to from what we used to do in the past. So first of all, I'm going to give you a layout of medications that patients commonly receive. This is, of course, can change depending on if you have allergies or a history of not tolerating these medications. Have this conversation with your surgeon before your surgery, that last appointment, before they give you the scripts to go home and fill, and they can adjust if needed. But generally, here's what we see. Tylenol, of course, also called acetaminophen, and meloxicam, also called Mobic. Those are different types of NSAID medications that you will most likely be taking scheduled after your surgery, so taking them on a regimen. After a few days of doing so, you will build up more of a therapeutic level of these medications that are constantly in your bloodstream, constantly giving you the effect of those medications, which gives us a nice foundation to build off of for your pain control. If those pain medications are not cutting it, I'm still uncomfortable after taking Tylenol, meloxicam scheduled how I'm supposed to, there are different medications you can take as needed. Most likely, the first go-to medication in this instance would be Tramadol, also called Ultram. This is considered an opiate pain medication. You will take that again as needed, as prescribed, and this pain medication many times will help you get back to that comfortable level of pain when taken in conjunction with those other scheduled medications. If it does not for some reason, your surgeon will most likely prescribe a rescue medication in that instance, and that's when you would take the oxycodone. And so again, it would be that you take Tylenol, meloxicam scheduled. If that's not working, that's when Tramadol is available to you. And if the Tramadol doesn't work, that's when you would take the more heavy-duty oxycodone medication. But as you can see, we don't take oxycodone or those types of opiate pain medications right off the bat and take it scheduled. We're taking others instead with less of those side effects, less of the risk, and only taking the opiates as you need to, when you need to. There are other medications you will receive in the hospital most likely. One of those is Toradol. This is an IV NSAID medication. You may get a dose or two during your surgery. This helps tremendously with getting you started on the right track for pain control. It works very well, and your surgeon will dose that in a safe way to make sure that it doesn't stress anything in your body, such as your kidneys. We do use a lower dose of that so that you tolerate it better and have a good outcome that way. But again, it gets you started on the right track for after surgery with pain control. Lyrica is another medication that you may receive. This one helps more with nerve pain. Lyrica helps with that burning pain that you may have around the incision, or with the sharp shooting pain that you may have from those nerves that are not real happy with you after having the incision and the surgery itself. And so, all these other medications we've mentioned already don't really help with that sort of pain. Even just a dose or two of Lyrica can have a lasting effect of helping suppress that nerve pain after your surgery. Again, this is one medication you would only receive in the hospital while you're here. Baclofen is another type of medication you may receive in the hospital. It helps with muscle cramps. It's a muscle relaxant. The idea is you don't really take it for really stiff muscles, but more of cramping muscles. To help with stiff muscles, your surgeon is okay with you using heat on the thigh away from the incision. So to be clear again, you can use heat not on the incision, but away from it on the thigh. Only use ice on the incision. But Baclofen is there in the hospital if you're having really cramping muscles, especially the top of your thigh. And if you're having that issue, talk with your nurse, and if you need to have that prescribed for home, we can adjust if needed. But again, it's only available in the hospital many times and only for those cramping type of muscles, and use heat if it's just stiff muscles. IV opiate pain medication. You noticed I haven't said anything about that yet. We really only use it if we absolutely need to. That means we've tried all of these different types of oral medications if we need to. And if those aren't cutting it, that's where we have IV pain medication available. If you also have really a big issue with nausea afterwards and you can't take pills and do that without having any issues with more nausea, then that's when it's also available to you for the IV opiate pain meds. And for example, by the way, those are like Dilaudid or morphine. So they're really only there to rescue you if you absolutely need it. We do not rely on those, and they are not regularly given to patients at all anymore. It's best to stay on top of pain. And so what we mean by that is don't wait too long for pain medications. Understand when they're due. So most medications are available every 3 to 4 hours roughly. Just because they are available does not mean you need to take them. So just understand with these pain medications at home, such as the Tramadol or the oxycodone, understand when they're available. You do not have to take them when they're available, but it's good to just check in and see how you're doing at that time when it's available next. And then if you don't need it, well, I'm going to give it some more time and only take it when I become uncomfortable again later on or my pain's not tolerable anymore. But again, stay on top of it. Do not let your pain get too high either. So, take it when you get to that 5 to 6 range. Be on top of it. Don't wait till you get to that 8, 9, 10 range because it's very hard to catch up to pain at that point. Main reason being that it will take up to an hour for those oral pain medications to kick in, and that means you're waiting another hour before that happens and your pain could get worse during that time. So be on top of it. When you get to be uncomfortable, take your pain meds, relax. Don't be doing anything to cause more pain during this time until it kicks in and starts working more. Other things you can do, take your pain medication with food. This helps you avoid nausea. And then other things you can do to help with your pain that's not medication related. Well, I already mentioned the heat on the thigh away from the incision. That's fine. And again, using ice on the incision. Deep breathing can help. Simply repositioning the leg can help with pain. Relaxation imagery, distraction, watching Netflix if you want to, rest, taking that nap, letting that pain pill kick in. All those things help with pain management as well outside of just taking a medication. Page 11 goes into how to best prevent nausea. First of all, let us know if you have a history of nausea with any surgery and we can make sure that you are getting the medication you need before surgery to prevent that. Start with ice chips. Advance your diet as tolerated, as I mentioned earlier. Always take pain meds with food, and that will help prevent nausea. And again, communicate with your nurse if you are experiencing any nausea. Medications are available if needed. So what this means is that, as an example, I've had patients who planned on leaving the same day of surgery. One of the holdups I've had is nausea. One patient in particular had some nausea the day of surgery. They didn't feel like it was anything to tell the nurse about. It wasn't severe, so they thought they could power through it. Then therapy happened. They got up and started moving and walking with therapy, and that nausea that they had all of a sudden became a lot more severe. We had to stop therapy, wheel the patient back to the room, and it took about 2 or 3 hours to get that patient's nausea under control. It can be really hard to catch up with nausea if you let it get too far ahead of you. So if you just get a little bit of nausea, let us know and we can nip it in the bud, take care of it, and you can have a successful therapy session and go on how you're supposed to with your recovery. Postoperative risks. I'm going to go over real quick the risks that are involved with these surgeries. Again, this is not to cause any anxiety. This is to go over how to make sure we have the best outcome, to understand the risks, and how to prevent them from happening. Page 12 goes over infection. Now, antibiotics are going to be given to you the morning of your surgery, and you may get a dose or two afterwards in the hospital. When you go home, you may be given antibiotics based off the surgeon's preference as well, depending on your risk factors. Take those as they're prescribed until they run out. Again, this does not mean that you have an infection going on if you are on any antibiotics. This is to prevent them. As far as the scrub that you will be using before your surgery. Again, when you use this appropriately before the surgery happens, this does reduce your risk for infection. Good hand washing will be performed. We'll do that in the hospital, you do that at home. Anytime you need to touch that incision at home, clean hands every time. Keep the incision dry. Now, some surgeons will want you to keep it dry during a shower. This means that you will put Saran Wrap Press and Seal around the dressing itself, take a nice quick shower, and then get back out, take the Saran Wrap Press and Seal off. It will not be too tacky for your skin where it causes any sores. That's what's nice about it, but it will keep you dry. If for some reason a little leak happened, that's okay. Either replace the bandage, or if you had the bandage off already, then pat dry the incision with something clean and allow it to air dry. If your surgeon allows you to get your incision wet during the shower, then again, take a very quick shower. Only briefly let water run over it with soap. Do not scrub it, and when you get out, do not rub it when you dry it, just pat dry. Make it very fast. Nobody will be taking any baths or going to any hot tubs where you soak anything. Again, there will be no water aerobics. You'll be surprised how many times I hear that one, but nothing where you soak the incision until your surgeon lets you know otherwise, and that is for every single patient. Discharge education will be given on signs and symptoms of infection. This sounds a little backwards, but we want you to recognize an infection fast, and we want you to let us know right away if that's the case. So this means if it's Friday and it's midnight and you look down at that hip or knee when you get up to go to the bathroom at night, and all of a sudden it's red and it's hot, that's a time to call, and you don't waste any time. You call the surgeon and let them know. If it's after hours, all surgeons have an answering service that will then guide you to what the next steps are. They contact the surgeon or whoever's on call, who then contacts you back. But just know that answering services are available after hours. The deal with this as well is recognizing it right away. The signs and symptoms are on page 12. Normal incisions will be pink. Normal incisions will be warm. But anything that is hot and very red, we do not like that. So, anything that is abnormal, follow what the list shows you. Call anytime if you're worried. You'll possibly need antibiotics prior to dental work, and this is even for cleanings. So there's certain periods of time, at least 2 weeks before your surgery, that we don't want any dental procedures done. And usually it's about 3 weeks. That's about the average I see that surgeons want you to wait for even cleanings after your surgery is done. Now these antibiotics, I'm not talking about a big long course of them. Many times what I have patients report to me is that it's amoxicillin, 4 tablets that you take an hour before you have your dental procedure done, even cleanings. And this will just make sure that for those patients who are higher risk for infection, that we have you covered. Your surgeon is the one to tell you what to do for this part. They will guide you through what to do, not the dentist, but your surgeon. Know that our infection rates are very good throughout our hospitals at St. Alphonsus. When you follow these procedures, you will see a difference in this outcome. As far as blood clots go, page 11 goes over the risks of those and what to look out for. What you can do to help prevent them is after your recovery, you'll notice exercises ahead of time. Ankle pumps is one of those exercises. Continue doing that after your surgery. So while you're laying there in your bed or in the recliner, pump those ankles, get the calves compressing, get the blood moving through, and that will help make sure that you decrease your risk for blood clots. Compression devices, whether that be something what we call SCDs, sequential compression devices. What those do is they pump up from a little compressor, and it either goes around your calf or your foot. It'll pump up, squeeze, push the blood through, and then it'll relax, and it just does that routinely while it's on. There may be compression socks that you use as well, if ordered by the physician. Just use those items in the hospital as directed. Blood thinners. Now, blood thinners are going to be ordered for every patient afterwards, and it'll vary based off your medical history and if you currently take a blood thinner. It can vary from anything from aspirin to Xarelto, Eliquis, Plavix. I see all different types based off what you have going on and what's going to be safest for you. If you are currently on a blood thinner, know that they will many times try to get you on that blood thinner after your surgery with what will be safest for why you take it and also for the surgery. So dose may change for slightly a slight period of time to keep the surgery safe, but know that you'll many times go back on that same blood thinner. Many patients anymore, I see them use aspirin as their go-to anticoagulant if there is no history of blood clot issues. Take that as prescribed when you go home. Now, when you are home, every 2 hours while you are awake, so please sleep through the night if you can, but while you're awake, get up every few hours and do something. I'm not saying exercise every time, but get up, go to the bathroom. Maybe the next time you don't have to go to the bathroom, but it's time to eat some lunch. So go to the kitchen and sit down somewhere and eat that lunch and then get back to relaxing. You can be up for about 15 minutes at a time, but then 2 hours of relaxation between that, okay? As far as constipation goes, we already talked about prepping yourself, and that will help make sure that you have a decreased risk for this. Also, afterwards, continue that regimen, especially if you are relying on opiate pain medication. Keep taking a stool softener or a fiber supplement. It may take 3 or 4 days before your first bowel movement. However, a good rule of thumb is if it's been a day or two since your surgery and you still have not had a bowel movement, and you've been taking these items I already mentioned, that's where you would maybe add in milk of magnesia or something like that. One of those heavier duty medications. If you need to do that and it's been a day or two, please take it. If it's been 3 or 4 days and you still do not feel a bowel movement coming, this is probably where you need to get an enema or a suppository involved now. And many patients can give that to themselves and do that safely. So if you need to do that, you can. If you have any questions about this, you can call the office and see what the next steps would be. But again, just remember, it can be 3 or 4 days before that first bowel movement. If you want to, you can increase your fiber in your diet. That's great. But if you want to increase your fiber, increase the water in your diet as well. And that will help make sure that the fiber actually works appropriately. Page 6 and 8 go over risk for falls. This is a risk that is easily preventable, and that is by being safe. So that means always call for help when you get up in the hospital. Even standing edge of bed, we need to be there with you. Don't ever get up by yourself or with family unless you are told otherwise. So again, no family is there right now. If that changes and family is present, then you can get up with them. But just know in the hospital, you need to get up with staff unless your therapist says otherwise. At home, use a nightlight, pick up, throw rugs, get all that tripping stuff out of the way. Nightlights, they're making them fancy now. You can get a nightlight that is actually motion censored, and the moment that you start moving and getting up out of bed, it's going to go off and you can see where everything is and safely get up. Please continue to use your walker until you are told otherwise. Many times the rule of thumb is you will use that walker until it is in your way. So until you get to the point where you say, I don't know why I'm using this, it's just slowing me down and I don't need it, then you can stop using it. Up until that point, use your walker and be safe. Many times, a lot of our patients are still using that walker to walk into their 2-week appointment. Pets, do not trip over your pets. So yes, remember the infection risk that can be involved with them, but also understand that they can pose a fall risk. So with your pet, know where they are at all times when you're walking around. Again, you will go home on a blood thinner. These blood thinners, again, will be prescribed by your surgeon and take as directed by your surgeon when you go home. This will reduce your risk for blood clots, but there are some side effects that are expected. You will be expected to bruise up and down that leg. Do not be surprised if it's all the way down to your toes and up to your butt as far as the bruising goes. So you will bruise, it's expected. You will bleed slightly more than normal. That is also expected. However, I'm just going to go over the risks that can be involved with any blood thinner, including aspirin. And always remember, any medication you take, there are side effects. But I'm going to go over the side effects that can be involved with those and how to prevent them from happening. If you do experience any of these items in red that I have listed here, then you contact your primary care physician or go to the ER. The first couple of them, vomiting blood. It looks like coffee grounds when you do this. It's just the way that blood is digested. It will have these brown or black specks in the vomit, or red or black colored stool. If you are taking iron, do not let this concern you. However, if you are not taking iron and you have the red or black colored stool, this can be a sign of a bleeding that's happening. Now, I have seen this not very often at all, but the few times I have were patients who went home taking aspirin. Sometimes NSAIDs can be hard on your stomach. the best way to take an NSAID is with food on your stomach. Now, aspirin, if that is prescribed, many times it is twice daily. It is best to take it with breakfast and then best to take it with dinner if that is the case. This will help it be digested easier. If you still get an upset stomach taking it this way, then you call the office and let them know you're not tolerating that, because we do not want you to suffer through 30 days or so of taking an anticoagulant like that. If you have a stressed out stomach trying to digest this for 30 days straight, that's where a gastric ulcer can develop. So just be on top of it. Let us know if you have any issues and we can help you out. Unusual bleeding that does not stop after an hour or red or dark brown urine. There are some medications that patients can be sensitive to and work too well on them. We want to find a nice threshold. Where are you safe with the surgery, with anticoagulation, while still being effective at preventing blood clots? If it is working too well where you're just bleeding and you can't get it to stop, you let the surgeon's office know or your primary care physician, and then they can dose you to the appropriate dose from there. If you fall and hit your head, you are at a higher risk for something happening as far as an injury goes. And the main reason being is that anticoagulants will cause, if there's a bleeding happening, it'll cause you to bleed more, or at least bleed longer. So this is why I mentioned already, we stress not falling. If you fall and hit your head, you're a higher risk for issues to happen with a blood thinner in your blood. So if this does happen, you call the office or just get checked out. But do not take this lightly. Be serious about it. We want to make sure that you stay safe. As far as miscellaneous information, driving. Do not expect to drive as a patient for 3 to 4 weeks after your surgery. First of all, that leg, whether it be left leg or right leg, it may be happening sooner or later. Can you use the pedals safely is the key part. So can you lift that leg and use the pedals easily and safely? That's your first check off. The next thing is, are you on any medication that can impair your driving? The example is opiate pain meds. Those will impair you. So please be safe with that. Once you can use the leg safely and you are off of anything that can impair your driving, that's when you can start driving. Your surgeon needs to be the one that helps make that decision with you. And if you need to get anything like a handicap placard for parking, the surgeon's office is the one who will help you with that. And lastly, we're going to talk about discharge planners. These are nurses, also called case managers, that just help with the discharge process, such as with getting different types of equipment that you may need, like we went over earlier. If you're having trouble getting a walker on day of surgery, the walker maybe isn't working for you, isn't the right size, having issues with getting a shower chair, they're there to help get that equipment only if you were unable to do so prior. They also help with other things too, for those patients who are ending up needing to have, say, home health, which is rare, but that may be the case, or even more rare, need to go to a rehab facility. That's what they're there for, to make sure that we can get you to these places. And of course, what's covered by your insurance and all that for all these things. What we also like to remind you during this time is when you are having an elective hip or knee done, is that many insurances do this as an outpatient procedure. It used to be years ago we did this as an inpatient procedure and you had a flat rate that you would pay. Now it's more of an outpatient basis, which means simply that you pay for the services you receive. And so it can vary depending on how long you are here or the services you receive. And if you have questions about this, talk with your surgeon's office. We do have a number that you can call, which is 208-367-2678. And that's 367 cost is what we call it. This is a number that you can call to get a priced estimate from St. Alphonsus for what we would estimate for your cost for having the surgery here. Again, 208-367-2678 for that number.